and colloquium. Let me start by acknowledging the traditional custodians of the many lands on which we meet. In my case, it's the Kaurna people of the Adelaide Plains, and I pay respects to their elders past, present and emerging, and to any Aboriginal and Torres Strait Islanders who are meeting with us today. The Sax Forum is something that we highly value to both engage with our members and allow our members to engage with each other. And we always are delighted to have suggestions for topics for these Sax Forums, because as you see today, we are able to attract high value speakers that can present on these topics and engage with you on the topics. And today it's implementation science. So thank you for all attending, and I will hand over to the CEO of the Sax Institute, Martin McNamara, to introduce our speakers and get the proceedings underway. Thank you.
Yeah, thanks very much, Ian, and appreciate everyone taking the time to be with us today. So for those of you who had a look at the program, we do have 3 speakers today, all joining us from different locations, so I hope that all goes smoothly for everyone. The first speaker is Dr. Liz Develin, who's the Deputy Secretary for Primary and Community Care at the Department of Health and Ageing in Canberra. Fantastic to have Liz with us today. She'll be followed by Professor Andrew Malat, who's from the School of Public Health and Sydney Health Partners, and then Professor Helen Skatiris, who is joining us from Canada, and hoping that the time works. She's the Head of Health and Social Care at Monash University as part of the Social Care and Improvement and Implementation Science Group. So following the third speaker, so following Helen, we will throw it open for a discussion on for people's questions and comments about what they've heard. And then we'll move to the Sax Colloquium, where I'll talk a little bit about the highlights of the last year and what we're planning for the next year. So that's the order of proceedings today. I might hand over to Liz to kick us off with the first presentation. And I think Karen Metcalf has got your slides, Liz, so they can be controlled from this end if that suits you.
That would be fantastic. Thank you, Martin. And good morning, everyone. Liz Develin. You might also note at the table I have Sarika Tolpale, who is a graduate in the Department of Health here, and whatever short straw she has drawn, she is shadowing me today. So this was one of her meetings, and that she'll participate in with me today. I thought I could throw the entire presentation to her, but I won't do that to her. As Martin mentioned, I'm the Deputy Secretary of what's called Primary and Community Care Group in the department, and I will give you just a bit of a cook's tour of what that involves, but also how that fits within the department before I make my remarks. This beautiful illustration that you can see is done by an Indigenous artist, Jordina Angus, who's a Wiradjuri woman, and it actually represents immunisation or vaccination going through the body. It was commissioned, interestingly, because after the COVID era, the rollout of the COVID vaccine was done completely separately in the department to the way the National Immunisation Program works, and we're now putting those 2 programs together. And so this piece of art was commissioned in representation of pulling sort of immunisation and COVID vaccines together. So if you're curious about the art, that's what it represents. But next slide, please, Karen. I just want to give you a sense of how I fit into the department, which will give you a perspective of perhaps some of the things I might say compared to, what other people in the Department of Health in Canberra might talk to you about. The department's effectively made up of 7 large groups. So you may be aware our department has about 7,500 staff across Australia. A big part of that is obviously the Therapeutic Goods Administration or Health Products Regulation. We also have the Interim Centre for Disease Control, and you would have seen announcements more recently that the funding for that has been assigned, and we are now beavering away on the legislation to have the Australian Centre for Disease Control established. But in the meantime, it's a bit like a group in the department. We also have what's called Health Strategy and First Nations Health. So sport is part of the health and aged care portfolio, one of those portfolios that quite often bounces around government, but it's in health at the moment. And this group's really a bit of a, not a mishmash, that would be unfair, but they do things, both strategic things like national health reform, look after sport. We have a lot of First Nations work out of there as well. We also look after aged care in the department, which is almost like a mini department in itself, but everything aged care, and very much responsible for the aged care reforms you may read about in the paper in terms of entitlements and those sorts of things. Our health resourcing group in the department is effectively, if you think about the individual benefits, whether that's Medicare benefits, the PBS, those sorts of things, and also do a fair bit in digital and technology. And then, of course, we have a corporate group in the department that looks after us. But the group I have the privilege of leading looks after primary care. So that involves a lot of our relationships with the primary health networks and other programs that are run through primary care. We have a large team looking after mental health and suicide prevention, which is a great focus of this government. Population health, which includes our priority populations, whether that's called women's health, LGBTQIA+, obesity, nutrition, tobacco, vaping. So they've done the great work on the vaping laws that have recently been introduced. We also have a team that looks after cancer, hearing and chronic conditions. So this is where you'll see our screening programs, for example. We also have hearing services programs. And we also have the National Immunisation Program. So that's the scope of my group. Across the department, we serve 5 ministers. So we have 5 political masters. Fortunately, I'm lucky to only have 3 ministers. So we obviously have the portfolio minister, Minister Butler. Then we have Jed Carney, who looks after a range of portfolio issues, but particularly in my space, that includes women's health and food regulation, for example. And then we have an assistant minister for mental health as well, Emma McBride. So just to give you a sense of the context in which we work, 3 ministers. I think I have over 800 staff in our group, so a big part of the department. Next slide, thanks, Karen. When I was thinking about what to say, I felt, I'm in a room of esteemed people, and not sure how much value I can add to this conversation, because I know many people online today have been working at this for a very, very long time. But I was reflecting on a fairly old journal article by Abby Haynes and others back from 2011. And the title of her journal article was Our World, meaning the researchers to the real world. So I have stolen a bit of that title. I've completely plagiarised it in terms of the title. But just some of my reflections, which I thought might provide a more unique perspective today. My background is I have worked extensively in the New South Wales government in different policy and program roles. I like to say to people that I grew up in New South Wales Health, working in both sort of health promotion, population health, but then also in more acute type things in terms of hospital service planning. I've also worked in central agencies in New South Wales government, and then also gone and worked in the more economic agencies, looking after things like planning, energy and water. And I've also worked in energy at the Commonwealth space. So now in the Commonwealth, returning to the health portfolio, it's been quite a really interesting perspective, I must say, from having grown up in New South Wales Health to now leading part of the Commonwealth Health Department. So I thought I would just reflect on the differences, because I know many of you will have relationships with both state and federal health department, or either or of those. And many of the programs and implementation science that you're interested in will have a bit of both in them. So I was just going to give you a sense of how I see perhaps the relationship and bridging that gap between sort of academia and policymakers can work. One of my reflections, which was a really stark one having come into the Commonwealth, is that decision-making in the Commonwealth, I think, is far more centralised and also far more constrained around the decision-making points, which are really the budget cycle and the MyEFO cycle. In New South Wales, that was not my perspective. I think in having worked in the New South Wales health system, we had far more opportunity to think about things outside of the cycle. And when we were ready, we'd probably go to government and say, we've got a great idea. Has somebody got some funding for it? In the Commonwealth, it's a very, very tight regime between the budget cycle and the MyEFO cycle, with very few decisions thought about outside of those cycles. And so it is quite an art, I must say, for both the bureaucrats involved, but also their partners in research agencies, when we have a good idea, to make sure that whatever we're thinking fits into that cycle. Another observation that I have from the Commonwealth versus the state level is, at the state level, I generally found treasuries were really, do we have enough money or not? That was their greatest concern, was how to either stop funding something or find funding for it. At the Commonwealth level, there's far more a role for Prime Minister and Cabinet and Treasury to have a policy view on whether what is planned is good policy. But I must say, we also work far more closely with our Department of Finance, which is going to give us far more scrutiny of how we're planning to invest and whether the investment amount is right, how much we're putting towards evaluation and those sorts of things, which is a uniquely Commonwealth role, I think, for a Department of Finance. They don't seem to play that role as much at the state level. So again, it just means that when you're working with health departments, that they will have more partners in the bureaucracy that they need to convince of a good idea. I'm sure many of you who have worked with Commonwealth health departments, and I certainly felt this frustration when I was a state public servant, that the faces and names would continue to change at the Commonwealth. You'd be dealing with one senior person and then there'd be another one not long after. And that really is because of a fundamental position in the Commonwealth, that it's really helpful for public servants to have worked in a range of portfolios. So people do move around a lot more. They seek bureaucrats that have worked in a range of portfolios rather than necessarily just honing their expertise in one. I think that's slightly different compared to state health departments. The people that I used to work with in New South Wales Health knew a lot about health. They were trained in health. That was their career aspiration, and many of them would never have thought about going and working in any other portfolio. So it does mean a very different nature of the relationship with the people that you're working with. And I was reflecting on it and thinking, how can we develop good relationships if the Commonwealth bureaucrats are always turning over? But I think it is trying to establish beyond the personal ones, but really the sort of functional relationship with the function of whatever is being delivered. So with, in my example, it might be, having a relationship with the immunisation program as opposed to the person who runs the immunisation program. So we need to be just really mindful of that. One of the other things that I reflect on working in the Commonwealth that is particularly different is the level of control over when we do decide to implement something compared to at the state level. We are incredibly removed at the Commonwealth level, which we've seen history has shown that when they do try to implement something, it can be a terrible disaster sometimes in other portfolios. We've seen those sorts of disasters happen when the Commonwealth tries to implement things. So we do find that generally we're a funder, quite often not even the commissioner, but funding the commissioning agency. And I think that introduces real implementation challenges for us. One of the most exciting things that we are planning to implement at the moment is the next, the first National Lung Cancer Screening Program in Australia. It's our first screening program for a very long time. And the complexity of working between what effectively will be GPs who will send people off to get their screen, to then the state system should people be identified, and then back into a Commonwealth system with a whole range of other partners in between, and a bunch of medical colleges that have a view on how this should all work. So I think some of that implementation science gets even more trickier at a Commonwealth level than at the state level, when there might just be fewer players and you might be able to control the levers slightly more closely. The other thing I've observed in the Commonwealth is the power of the lobby groups is probably more powerful and perhaps different ones. And I won't name them, but obviously some of our colleges have incredible power. Some of the health workforce unions, I might describe them as, have incredible influence. So we do like to include them in the tent very early. And I think that's an important part of both our evaluations and our planning of implementation, is to include those sorts of stakeholders early. In the Commonwealth, we also have some really, really powerful processes that if we can find a way to use them, they're incredibly powerful, whether that's be through, PBAC decision-making mechanisms, whether that's MSAC, ATAGI, those sorts of things. And they're really held up in very high regard, I must say. And across the political spectrum as to using them and implementing their advice. So I think the more we can find those really quite rigorous processes and use them to our benefit, we'll be in a good space. And just the final piece of complexity that I've observed in the Commonwealth that we quite often don't need to deal with at a state level is international relations. So we've had a very live example in food regulation in Australia, and obviously our food regulatory system we do in a cooperative way with New Zealand, as you can imagine, with the products moving between the two countries. And their government has quite a different view to ours on particular things that particularly the public health community would think are very important in Australia. And New Zealand currently has quite a conservative government. And so we need to navigate that in a really interesting way from a public health perspective, which probably if we were in a state, we might, cross-border issues might be our biggest challenge rather than across the ditch issues, for example. Next slide. Thanks, Karen. I'm very, very careful here not to tell people who have been doing this for a very long time how to suck eggs, but I do always have to remind myself and sit back and think about how I feel that we can develop really enduring relationships between researchers, evaluators and government, and having worked at this for quite a long time. So like anything, relationships are super key, both in terms of bureaucrats knowing who in the academic or scientific sector is really powerful to us. And this is something that I've been working on very hard at the Department of Health here in Canberra on, is when people come to me and I say, okay, well, who are the academics who are working on this issue? How are they partnering and helping us? And so I think that's something I'd really like to encourage more of, because I don't think it doesn't always happen at the Commonwealth perspective that people know exactly who's who in the academic community and who's best to help them. So I think there's more work for us to do in that way. We do often quite get proposals lobbed in for a good idea, but there's been no consideration of how the delivery would work or how those delivery partners would even view the proposal or those sorts of things. So I think the more we can work together in identifying, if it's a good idea, good policy idea, who on earth would be implementing it in the first place and how do we bring them on early. I'm sure Andrew will talk about this. He and I have had many conversations over the years about how to scale programs. But it's an incredibly interesting thing when you work at a national scale of capacity, and particularly capacity across Australia on how to deliver a particular health intervention. We often have conversations, and I can hear my minister's words ringing in my ear when he says to me, I just don't want a program that works on the Eastern Seaboard, please. And that is a real challenge for us to think about programs nationally and how you scale them for all the communities that we need to serve. But have a mind to that whenever we're designing something. Program versus intervention. I must say quite often we find people have a very, very niche good idea about a very, very particular health issue, and that they wish GPs would just do something with patients on this particular issue. And I guess when we start to explore and how would a government implement something like that in terms of the levers that we have, whether that's incentive payments to general practice, whether that's the MBS system or the PBS system, quite often that thinking has not been encapsulated in the design of a very particular intervention. So I think the more we can think at a programmatic scale about how this program would work to get that intervention will be really important to us. Playing politics is very high risk. I must say I've seen some researchers and evaluations do it in a wonderful way and others fall in a burning heap. So I do counsel people against this. People quite often say when we have the conversations about how to fund something or they've got a good idea, oh, well, should we just go to the minister? That's the quickest way to piss off a bureaucrat, to be perfectly frank. But we can help you navigate that space. And particularly coming from a public health background advocacy is an incredibly powerful thing if it's done in the right way. And we have some wonderful partners in the NGO and advocate space who do great work for us behind the scenes. And I think the more government employees, bureaucrats can work with people behind the scenes to get really good policy up, that's a super thing to do. And of course, just going back to my introductory remarks around the budget cycle being an incredibly powerful thing, particularly in the Commonwealth. We routinely, ERC is effectively, most people would conceive it, the Expenditure Review Committee of Cabinet being where the financial decisions are made, but it is actually where a lot of the policy decisions get made, plus the funding. So we work very much to the cycle of the Expenditure Review Committee in terms of new policy proposals. For example, ERC is sitting today. We have several. We may see them announced, or they may become election platforms, who knows, but that is the way the Commonwealth really works. It's quite a treadmill and a quite disciplined process of getting things into that budget cycle. And to be perfectly frank, very difficult for government to consider things outside of that cycle unless it's an emergency measure. So we do work to those. And so the more you can familiarise yourself and your partners in government in working to those to get good ideas up, that's super. The one thing I haven't mentioned on this slide is another observation is we always, generally when we go to government to want to fund something new, put aside money to evaluation, and that's an expectation of government. I must say, however, I get disappointed sometimes in the partners that we choose to do our evaluations, and quite often that's because we're choosing private sector consultants. And so I do think there's still a lot of work for us to do to overcome that gap of how agencies such as the Department of Health use our friends in the academic community more to do evaluations of implementation, and less use of private consultancy companies who do not have the expertise. And it's about how quickly people can respond and get in. But I think that's part of us working with you early in the design of programs so that when we're ready to commission the evaluation, you're right there with us. But they are my comments. If we go to the next slide, Karen, I'm just going to, this is my wish list of things that I would love the community to start thinking about. So these are some of the big issues just in my group, topics of great interest for both research and evaluation. We are seeing increasing vaccine hesitancy. Australia's immunisation rate for our 5-year-olds is less than 95%, different in First Nations communities as well, sometimes quite lower. And it's a real implementation challenge for us, because if you think about the fact that there's about 300,000 babies born a year, so if it's only sort of 1% of parents, for example, that aren't vaccinating, that might be 3,000 parents we need to convince, and we're sitting in Canberra working out how we reach those 3,000 parents, which are probably not very close to Canberra. So I think vaccine hesitancy, and particularly this is linked to the rising misinformation that we see across the world, and how we, as public health people, try to counter that will be really interesting. Youth mental health is an enormous interest for the government, and we're going to have an amazing natural experiment with social media bans, whether they work or not, which will have a great deal of tentacles, no doubt. We're very interested in it from a mental health space, but I can imagine there's other parts of public health. You know, you can imagine food marketing to children and all those sorts of things about what social media bans may or may not do. In primary care, we are really seeking to drive over the next 5 to 10 years a system which is less about fee-for-service and MBS billings and more about blended payments to the primary care sector, which will be both a very difficult economic exercise to design, an incredible stakeholder one, but also I'm more interested in, does it change any health outcomes for the patients in primary care? We've got an amazing experiment coming with the introduction of a lung cancer screening program next year, which will be a very, very interesting because of the complexity of the stakeholder group. In terms of alcohol, there's the evidence continues to grow around the relationship between alcohol and violence against women. We do see interesting things, you know, about the supply and location of alcohol and increase in violence against women. So a super interesting area for the government in the context of family and domestic violence. The vaping space continues to be super interesting and super sensitive. And I think, you know, there's almost a few interesting natural experiments happening across Australia where the Australian government has sort of, through the Therapeutic Goods Act, has made changes to the availability of vapes, but some jurisdictions will go further than that and have different regulatory controls. So that may create some interesting natural experiments for us. We're also very interested in gender bias in the health system. You know, we've done some research recently, which would suggest about 2/3 or 80% of women can tell you about the time that they certainly experienced it. And quite often that was in primary care. And that is nothing against primary care, but that's largely because that's the first port of call for people in the health system. So we're very interested in that. And I think it does link to research in the fact that quite often research is not reported on women specifically. We know that research into drugs on pregnant women doesn't happen. There's a whole bunch of things that just don't happen. The government's very interested in urgent care clinics. So this is where the Commonwealth is effectively standing up free walk-in urgent care clinics on the premise that they hopefully reduce emergency department presentations to the local hospital. Very interesting natural experiment again to see what's happening to emergency departments. And we are super interested in the LGBTQIA+ community as a priority population. We know they have far poorer health outcomes, and so we're doing lots of work in that space. So these are my sales pitch for interesting topics. If anyone has great ideas that they want to come and chat to us about or is doing something interesting, these are just sharing my interesting tidbits. But back to you, Martin. Thank you.
Firstly, thanks so much, Liz, for what was a really frank and forthcoming presentation. I do really appreciate it. I'm sure everyone really appreciates having a better understanding of the world you operate in. So really, really appreciate that. And it's also great to hear about the interest and enthusiasm you have for engaging with the research community. I think that'll be really positive. And those topics of interest, I'm sure lots of people are already scurrying away with ideas about how they might be able to help respond to some of those areas also. So I think, Liz, your time is quite short today, if I remember correctly. If anyone does have any questions for Liz at this point, please do feel free to add them into the chat or even ask them directly. We are about to move on to the next presentation in the next minute or so from Andrew Malat. But given Liz's time is a little bit shorter today, if anyone's got any particular questions that they wanted to offer up at this point, please do so. I'll just give everyone a minute or two to do that. See if anyone has anything to add. So Monica's got a question. Go ahead, Monica. I think you're on mute, Monica. Is it?
Apologies. Thank you so much for a fantastic presentation. Can I just ask a little bit about the lobby groups, Liz, and sort of the pros and cons about that? So I'd be really interested on how you see them fit into the budget cycle and yeah.
So I won't name any, but you can imagine there might be ones like colleges of GPs or the AMA, for example, not using them specifically, but incredibly powerful lobby groups that have incredible media presence in terms of whether a policy is going to work or not. And so we find that we have to have absolutely spoken to them in a very extensive way prior to even making suggestions. There's also an expectation that we work very closely with those stakeholders in the design of programs. And whilst government will, of course, always sometimes choose to do things that may upset our stakeholders, they will have been in the tent very closely on the way. I must say, however, it gets incredibly difficult in sort of circumstances where you can't keep them in the tent. And we had some interesting examples with, for example, vaping regulation with a particular model introduced by the Australian government and the Parliament, God love them, and particularly the Greens, decided that a different model should get up. And unfortunately, you know, very difficult to work with the pharmacy sector in between the introduction of the legislation and then what the Parliament voted on. So I find we have to work with them incredibly closely and keep them in the tent because of their powerful media presence.
And has there been a specific evaluation done around that topic, Liz, or would that be something that would be worthwhile potentially to, I guess, understand the interest a bit more from a data side?
Oh, potentially. There are so many avenues of inquiry. So many avenues, Monica.
Right.
Yeah.
So there's all. Oh, sorry to interrupt, Liz. There's also one other question in the chat about MyEFO and whether that process is the same for all parts of government. Is just wondering about the timelines and the process around MyEFO. I'm assuming there's consistency. Is that right across different parts of government?
Yeah. So that is a whole of. So I must say, in the state processes, I come from New South Wales, but so other states might have a different one. MyEFO was not a big thing. Whereas in the Commonwealth, it is genuinely part of the budget cycle in a far more disciplined way. And so, it happens at the same time. So we are in MyEFO right at the moment in terms of government making decisions halfway through the year. And then the state, but normally the Commonwealth budget would come out in sort of March or April. So always the same sort of cycle. And it really is when the Commonwealth budget came out in March or April or whatever it was, we were then on the treadmill for MyEFO coming up. So it's very much a continual 6 monthly.
Yeah. Okay, I think that's all the questions that are coming up right at the moment, Liz, but thanks again for all the contributions and input today. Really do appreciate that. Let's go to the next speaker, which is Andrew Malat. So Karen, if you could bring up Andrew's slides, that would be great. And just to remind everyone, Andrew is a professor of public health at the University of Sydney and is also a senior advisor at Sydney Health Partners. And many of you would already know Andrew. He's also spent a lot of time working in New South Wales Health over the years too, so it brings a great perspective. Thanks, Andrew.
Thanks, Martin. And it's a hard act to follow. Liz's experience is quite amazing across government, but Liz has also had quite an influential role in a lot of the portfolio of prevention policy in New South Wales as well. She was one of the initial architects of what became the Healthy Children's Initiative and some of the best examples of scaled up initiatives that we have in population health. So just wanted to thank Liz for her contribution to establishing that system. So today's presentation is, I'm going to drill into a bit more detail around implementing innovations at scale, but also sustaining their impact and why that's a challenge for health systems, but also some of the things we need to think about in terms of implementation science that may support getting interventions to scale and maximising health impacts. So as Martin said, I'm a professor of public health at the University of Sydney, but I also work for Sydney Health Partners as a senior advisor. And Sydney Health Partners is a partnership between 5 health services and LHDs and the University of Sydney. It's focusing on increasing the amount of research translation that occurs, and it has clinical academic groups that bring clinicians and academics together to do research. It also supports clinical trials and consumer engagement, but also runs an implementation science academy, which I'm part of. Okay, next slide. Are the slides moving? Okay. All right, I'll go through now. I'd also like to recognise and pay respects to elders past, present and emerging, and on the various lands that we're meeting upon here today. Okay, so why is scale up important? Well, the lag between evidence generation and implementation at scale really is a considerable impediment to health improvement, simply because it denies or delays the community's access to effective services. And as you can appreciate, if people are implementing interventions that are based on old evidence and not the latest evidence, often we see an evidence practice gap. To highlight this, so Braithwaite and colleagues, including Runciman, have done a series of studies called the Care Track studies within the Australian context. And they talk about the 60-30-10 challenge. And this is a very real challenge that is being demonstrated not just in Australia, but in the United Kingdom and the United States. And over almost 2 decades, we've seen consistently, whether it be in primary care or in hospital care, that there is an evidence practice gap. And about 60% of the care across those different contexts is evidence-based or aligned with clinical guidelines. About 30% is low to no value care. And concerningly, about 10% of that care that people receive is harmful. And to highlight this challenge, really that evidence practice gap, the real challenge really for health systems is not so much introducing new technologies all the time. So it's also taking the existing evidence and applying it across whole systems. So Emmons and Colditz did an analysis of cancer prevention evidence, and they suggested if that was applied in 2017, more than half of cancers could have been prevented by applying that knowledge. So what is scaling up? So scaling up is deliberate efforts to increase the impact of successfully tested health interventions so as to benefit more people and foster policy and program development on a lasting basis. There are a couple of important elements to this definition. Scale up by its very nature is deliberative efforts. So it's not producing research in peer-reviewed journals and publications and sort of getting it out there and hoping that it gets adopted. Often scale up, and most commonly scale up, is done by people who operate systems, who fund systems. So it's a really intentional strategy, and it differs from research translation. So what's the difference between implementation science and scale up? Well, they have both evolved from different backgrounds. Scale up has predated implementation science, in fact, and it started in many low and middle income country contexts. And that's where we see the most comprehensive examples of scale up, believe it or not, in low resource settings, particularly in the areas of public health and infectious disease control, while implementation science stemmed from the evidence-based medicine movement and was about implementing models of care or evidence-based interventions and trying to accelerate that process of research translation. The reality is you can implement without scaling, but you can't scale without implementing. And now I think these two fields have converged, and scale up really is a subset of implementation science, and implementation science provides a useful set of tools that can be used to improve the scale up of interventions. So what do we know about scale-up processes? And I'm sure Liz and other speakers and people on the call would really talk to the fact that scale-up really is non-linear. It's inherently complex and very political. And it's understandable given the fact that when we are scaling up things, we are often talking about, hundreds of millions of dollars. We're taking something, if you look in the forward estimates of implementing a program, it very quickly adds up to a lot of money. So by virtue of that, it is a very political process. But when we are scaling things up, it's important to be clear about what types of things we are scaling up. And Brown and colleagues talk about the 7 Ps, which are programs, practices, procedures, policies, products, and pills and principles. But in reality, you can scale up anything as part of a system. It can include regulation, better planning, management tools. And inevitably, if we have an evidence-based intervention or a practice, if we want to scale it up across a whole system, we do need to sort of have a multi-strategic strategy. It's just more than just the evidence-based model of care. You need to think about practices that can be adopted, procedures, policies, training. So often when we are scaling things up, these are multi-strategic efforts that are resource intensive. So thinking about scale up, it's important to sort of understand what we are talking about when we are scaling up. And often it starts with a local pilot. Will go across the district, in many districts, state, national, international. That's the sort of traditional pathway. But it's important to understand that there are 2 critical concepts, one of which is reach. And reach is the absolute number and proportion of individuals from a target group who are willing to participate in a given initiative. And it's an important concept because often when you hear people talking about the fact that they've scaled something up across a district, let's just say a local health district, when you scratch the surface, you realise that they're maybe only implementing it in 3 of 10 hospitals. And within those 3 of 10 hospitals, they may only be reaching about half of the eligible population group for that particular intervention. So if you do begin to apply the concept of reach to program delivery, you quickly realise the reach is low and it could be higher. And really the benefits that we need to derive from the evidence-based models of care can only be done so when we increase the reach. The other important concept is that of adoption. And adoption really talks about the absolute number and proportion of settings and staff willing to implement an intervention. So scale up is a combination of reach and adoption. And critically, we can only maximise health impacts when we actually have done both and focus on both. So this is a study that we conducted a couple of years ago, led by Develin, and we tried to look at, in reality, what were the pathways for scaling up public health interventions. And we looked at scaled up chronic disease preventions and backtracked them to see what evidence on which they were based. And through that process, we identified 4 typologies, the first of which was a comprehensive typology, which started up with a promising idea or a pilot, was tested in efficacy with a bit more of a tight research design, often randomized controlled trials, then implemented as a real world trial under real world conditions, and then scaled up. The second type was an efficacy emitter, which started with the great idea, then did a real world trial, then was scaled up. Third was trial emitters, which started with the great idea, was tested in an efficacy context, and then jumped straight to scale up. And the final and most concerning typology was that of dissemination at scale. And this is where something started from an idea and jumped straight to scale up without any discernible evidence on which it was based. So if we looked at the proportions, concerningly, about 15% of everything that we analysed as part of this study was based on no evidence that we could find. 25% were based on trial emitters. So they essentially were tested in efficacy studies and then jumped to dissemination. Now, I'll tell you why I think that's a concerning phenomenon in the next slide, which is due to something called the scale-up penalty. So the scale-up penalty is essentially where we do something in a randomized controlled trial, and then we implement it later in an effectiveness study or a dissemination study. And what we see is a decay in the effect sizes. So this is a study led by Sam McCrabb, which I was part of with Luke Wolfenden's group. And it was a systematic review of trials that sought to deliver obesity interventions to populations at a larger scale than the preceding RCT. And this study particularly found that there were typically around 75% less of intervention effects reported in pre-scale-up efficacy trials. So this is a concern because this really does overestimate intervention effects. So if we just assume that we're implementing an intervention based on an efficacy study and apply that across a whole system, in all likelihood, we are going to have an intervention that isn't effective. So that's a really concerning thing, and the reason why we do need to go through an evidence pipeline when we are scaling things up. So how do we view the scale-up process? So this is a study by Barker in an international development context, but they talk about scale-up really as a series of quality improvement activities using the Plan, Do, Study, Act cycle, starting off with small tests, moving on to small-scale tests of change in multiple sites, and then widespread implementation with local tailoring. Another way to think about scale-up, but also implementation science, and this is a fantastic paper by Cassandra Lane and John Wiggers and Luke Wolfenden that they've recently published on a learning health system, and they talk about how they've created a learning health system in population health in Hunter, New England, but essentially has 3 phases where we do knowledge to practice, which is beginning to think about an intervention, doing formative research, piloting potential interventions. The second phase is around practice to data, and that's doing research to evaluate intervention effects and really establishing some of those data collection systems about what's being implemented and how. And then the third step is to do data to knowledge, which is research to identify the opportunities for improvement and scaling up these interventions. And they have 6 pillars, which include the importance of practice data and management systems, workforce development, governance, evidence surveillance, synthesis, importance of partnerships, and multidisciplinary scientific expertise. And interestingly, if you look at the evidence around effective scale-up, a lot of these elements are in this learning health system model. So I highly recommend it as a useful tool to think about how you might do implementation science and scale up. But the reality is, when we are scaling things up, and I'm sure Liz's presentation highlighted this, that there are many types of evidence that really influence whether things are scaled up, and research evidence is only one part of that picture. And often decisions to scale up interventions are influenced by so many different things: stakeholder interests, political ideology, economic climate, public opinion, the legislative frameworks within which things operate. So it's really multidimensional and multi-strategic, but we should, wherever possible, try to make research evidence play as large a role as possible in implementation of interventions. So there are some scale-up frameworks and tools out there that may be of interest to people. The most commonly used scale-up guide is the WHO WHO ExpandNet guide. But we've also developed guides for New South Wales Health when I was working there on scaling up health interventions. We've also developed something called a scalability assessment tool, which should be the first step in any scale-up process, where we are really assessing interventions as for their suitability for scale-up. which involves assessing effectiveness, potential reach and adoption, alignment with the current context, acceptability to stakeholders. So it's a systematic process of going through and assessing potential interventions to determine whether they're appropriate for scale up. And this tends to be the step that's missed. And this is where you see examples of things that are not evidence-based being scaled up across whole systems. So scale up is only one part of the process, and critically, health impacts can only really be maximised when things are sustained in health systems. So talked about how challenging it can be to scale up things, and the reality is there's only a very small proportion of things that are implemented across systems consistently at scale with appropriate levels of reach and adoption. But those that do make it, really the health gains are made where we see sustained impact over time. So the other part of this story is the importance of sustainability. So what is sustainability? Just like to thank Nicole Nathan for some of these slides. And she's, in her presentation, she talks about after a defined period of time, a program, clinical intervention or implementation strategies continue to be delivered, and individual behaviour change is maintained, and that program or individual behaviour may change or evolve or adapt while continuing to produce benefits for individuals and systems. So they've done some fantastic work here to try to quantify how much sustainability research is done. So Nicole Nathan and colleagues, so they did a review of the top 10 leading public health journals in the world, and they reviewed the articles there, and they found that only 1.3% of papers focused on sustainability. Of that 1.3%, most were descriptive, focused on methods. And interestingly, a couple of studies there did review interventions that were implemented and to see how often they are sustained after being involved in a sort of quite a substantial research project. And interestingly, they only found that between 0 to 23% of those interventions were sustained after 12 to 24 months, once researchers pull out and they're left in the normal practice environments. And interestingly, only one study assessed the effect and tried to do this in an experimental design of specific sustainability strategies to support the continued delivery of an intervention, highlighting that this is an area where a lot more research needs to occur. And Proctor, a famous implementation scientist, talks about sustainability as the most significant translational problem of our time. So from those limited studies, so what are some of the factors that do contribute to sustainability of evidence-based interventions? Well, these are sort of common sense things, and certainly my lived experience as a policymaker for 27 years, these things ring true, but this is what these studies have indicated. Interventions can be modified over time is a really critical component. You can't have a static intervention, but you also need to operate with caution and ensure that you're able to implement things with some fidelity. Champions are critical, and those champions need to be at the coalface, but also within the leadership of organisations. Innovations need to fit with the organisations and their mission. And you can sort of see this, things will inevitably fail if it runs contrary to, the culture of an organisation, its mission. You need clear benefits for staff and or clients for interventions to be sustained. You need organisational and leadership support, and some barriers to sustainability identified were, and these once again are common sense, but it's good to see that they are found in the literature, is insufficient funding and resources, staff turnover and the challenge of keeping people across the actual intervention and its implementation, and lack of ongoing training. So in conclusion, implementation of effective health interventions at scale and their sustainment is essential to improving health outcomes. Really, we can only maximise those health outcomes if we try to close that evidence practice gap and implement things at scale. And we need to, health impacts are maximised when we do that. Optimal ways of really expanding and sustaining programs has received inadequate attention in health systems and academia, and critically, data, performance monitoring, feedback systems, but I would also put in there effective governance are essential to sustainable practice change and maintaining a political will for interventions. And that's it. Thank you.
Yeah, thanks very much, Andrew. Fantastic tour of implementation science, and really interesting to see the potential for implementation that you're describing, and what the return might look like if implementation was accelerated, but also the kind of pitfalls if it's not carefully considered. That scale up penalty, really fascinating. So just in the interest of time, we might move on to Helen Skatiris, who I can see seems to have joined us, which is great. So welcome, Helen. Are you with
Hello,
us?
everyone. Can you hear me?
Yeah, great. Thanks, Helen. So just to
Fantastic.
quickly introduce Helen as the Professor of Health and Social Care Unit at Monash University. So over to you, Helen.
Thank you very much. And thank you, Liz and Andrew. I arrived 5 minutes late, but I heard your fantastic presentations. And thank you so much, Martin, for this invitation. Very happy to be here. I too would like to acknowledge the traditional custodians and the lands on which we're all meeting and pay my respects to elders past and present. So next slide, please. Sorry, someone else is working the slides for me. You'll have to press it again. Sorry. Thank you. These are my parents, Bill and Angela Skatiris. This was taken at the top of my mum's village in Greece several years ago. You can see the pain in their face. They were migrants to Australia in the early 60s. They left their parents and large families because their parents couldn't afford them. And they were raised and lived in pervasive poverty. They are not educated. They didn't even finish primary school, but they were invited by the Australian government to come and live in Australia. And at that time, there was free education, free health. There were employment opportunities, so they were able to work, and they worked their whole life. Next slide, please. And this is the result of a life where you are supported, where you can actually lift yourself out of pervasive poverty. This is my family, and we are all not only tertiary educated, but obviously, you know, you all know I'm a professor. My partner is also extremely successful. He also is born to migrant Greek parents, and my two children are now tertiary educated and employed and doing very well. So we live a complete life of privilege in one generation that was reversed. So next slide, please. I'm a developmental psychologist. My focus has always been maternal and child health and wellbeing, the best start to life for all children. You could probably guess why that's the case, that I've always been interested in supporting children to move beyond their birth circumstances, as was the case for my parents. So the next slide, please. I've moved my research over time from what we know matters in terms of children's development to what we know works. I've done many, many randomised controlled trials, and now I'm focused on what translates, that really pointy end that we all end up, you know, falling into that valley of death and not knowing how to get out of it. So we're very good at randomised controlled trials, but we're not good at translation and implementation. And so next slide, please. This is an example of a program of research. I want to give you a real-world example of implementation and scale-up to help you understand the complexities that Andrew and Liz have already talked about. This is a Healthy Eating, Active Living Matters program that has been designed and offered to young people who are living in out-of-home care. Young people living in out-of-home care have been removed from their biological parents because of sexual, physical, emotional abuse. And they are adolescents and children living with most disadvantage and vulnerability. They are also children and adolescents living with larger bodies. They have 2.5 times the prevalence of obesity than typically developing adolescents. So I developed the Healthy Eating, Active Living program. Next slide, please. Which was a very behavioural and psychological intervention that was focused on overweight and obesity. It was very top down. And of course, when I was funded by an Australian Research Council linkage grant to run a randomised trial, there was complete resistance from carers, many of whom are also living with overweight and obesity. Next slide, please. So Little Miss Know-it-all, me, next slide please, should have arrived to this study with a t-shirt saying, I'm a professor, to save time, let's just assume that I'm never wrong. And the reality is I was extremely wrong. I had no lived experience of the sector of out-of-home care. I had no lived experience of the life and the trauma that these young people are living with. As you can see from the initial slide that I showed you of my family, we are the complete opposite. And this is what happens all the time. We as researchers, we as professors, we as a certain type of demographic want to support research with populations that are the complete antithesis. They are so different to us, and we have no lived experience of that. So next slide, please. So that for me was a real defining moment in my career. I completely flipped the paradigm and the way that I work. And what I do now is I listen to the needs of industry and community and offer my research and service. And so those hands mean that I'm connecting with community, listening to their voices, and literally my research is being led by them, as opposed to the top-down driven approach that was Healing Matters to begin with. Next slide, please. So I'm moving away completely from an investigator-initiated to strategic prioritised research, and that's the only way that we can actually put the pieces of the puzzle together. The next slide, please. So Healing Matters actually did become, dropped me, forgot about what I think is important, and brought in lived experience of young people in out-of-home care and those who care for them. And we co-designed a program now that is included as best practice in Victoria, is included in Victoria's most recent Healthy Kids, Healthy Futures 5-year action plan. It's being scaled. It's being scaled up across Victoria, South Australia, parts of New South Wales as best practice in out-of-home care. It's being adapted in Belgium and in the Netherlands. It's award-winning. The Victorian government has funded me and my team for another 3 years. We're also developing health promotion guidelines. I should be really happy, right? I mean, this is exactly what Andrew was talking about. You can have implementation without scale up, but you can't have scale up without implementation. And this is scale up. However, there's a really big but. Not all children are benefiting, and Healing Matters and an equity process was not embedded from the outset. It was an afterthought. So I, unfortunately, again, made an error in my research judgments. And with the co-design process, I did what we mostly do, and I left behind Aboriginal and Torres Strait Islander children who are overrepresented in out-of-home care, LGBTIQA plus young people, again, many of them, young people with a disability, again, many of them, and refugee and migrant young people who are in out-of-home care, again, many of them. So in actual fact, Healing Matters was an equality type of program. It was available for everybody, but there was no equity in the way that we implemented it for scale up. Next slide, please. So we know that the inequities are widening between those who are in a more privileged position in society and those who are not. About 18% of all children are now living below the poverty line, which is absolutely unacceptable in a high-income country like Australia. So this is where equity matters and must be an explicit focus of our implementation strategies. Next slide, please. So how do we genuinely embed equity in implementation science, despite hundreds of, probably about 150, despite about 150 implementation frameworks, theories and models, the how to use implementation science to advance equity is largely unknown. In fact, actually, I probably can be safe to say that all of the theories and models and frameworks have been developed by by people like me, very Western, Eurocentric and colonised actually. We haven't incorporated global South views and diverse views, and we definitely haven't incorporated the voice of lived experience. So it's mainly and predominantly researchers and clinicians from the US, the UK, Canada, Australia. So I was awarded a Maureen Brunt Professor of Fellowship by Monash to undertake and tackle this global issue. Next slide, please. And Maureen Brunt herself was the first professor and first woman chair of economics in Australia, and the first woman professor at Monash, and that was 1992, so not that long ago. Next slide, please. You can see there just a really lovely visual depiction of equality versus equity. And so Healing Matters, if we go back to that example, everybody could get to Healing Matters, but you can see that when it's just equality, not everyone's going to benefit in the same way. We really have to think about how to tailor and strategize for equity so that when young people, for instance, are afforded the opportunity of Healing Matters, they get it in the way that's best for them, which is what we're doing now. Next slide, please. So our vision is to develop Australia's first programmatic multi-sectoral study of equity-centred implementation science across health, social care and education. And that's the other innovation that we're bringing, because the other limitation of implementation science is it's very, very health and medicine centric. And that's actually quite hierarchical, because what we see is that medicine and health are more important, for instance, than community services, social work, early childhood education. There is a hierarchy in our society, and we need to break down not only hierarchies, but silos. And so we know that inequities are born throughout all sectors. So they're born in health, they're born in social care, and they're born in education. Yet, if you go to the world's, leading journal, Implementation Science, there is pretty much zilch on social care and education. And again, as I said, very much driven by health. So we're trying to break down those silos. I'll give you an example, next slide, of what we're doing. So first of all, equity is at the centre, and nothing is being done without our lived experience network. So that they are the voices of lived experience, and they are literally right with us right from the outset in every step of this program of research. They're not coming in, as consultants. They're not coming in as afterthought. They're actually right there, right at the outset, driving all of these programs. And we're focused on program planning, because you cannot implement, you can't have implementation if there isn't a program, an intervention, a resource, a strategy, a policy that you're implementing. So what we're aiming to do is to explore how equity is defined and how we can empower those who are planning, developing interventions and programs to actually embed equity right from the outset. The other thing that we need for implementation science, implementation research and practice, are strategies that support us to actually implement those programs that we've developed. And so we're doing a transdisciplinary review and going back to the importance of understanding through health, social care and education how equity is implemented in practice across those disciplines. What do we already know is out there and what's working, and how can we do this better? And the final one is conceptual understanding. So proposing a cutting-edge multidisciplinary model to advance the field of implementation science will also involve transcultural information as well. So it's not just transdisciplinary. Next slide, please. Because I'm a developmental psychologist, and a lot of the focus of this is the best start to life, it can relate to the lifespan completely, but obviously I'm interested very much in children's development. We also are including the voice of children, and we don't do that. We actually, if you work with educators in schools, they will be horrified to know that, we are not including the voice of children in many of the interventions that we're designing for them. So we're trying to reverse that and include children so that we can hear from them and understand, you know, the view of the world from their perspective, especially from an equity point of view. Next slide, please. So I'm not going to go through this detail, just to tell you, just to help you understand what we're doing in terms of equity in program development framework. So we're starting with the actual frameworks that are out there that help us to develop our programs. What do we know about overarching equity principles? What's been identified in the literature? We have done a very, very thorough scoping review. We have 85 articles. We are now coding those articles for overarching equity principles. There are just some there, but we don't have time to go through them. It's not that they're principles or factors that you would be surprised in, but we haven't synthesized this scope of information in this way before, and that's what's really important to do if we're going to move forward with equity. Next slide, please. So that's just looking at an equity mindset in terms of intentionality for equity. You know, how can we do equity intentionally? How can we do it explicitly and not, as I said from the outset, in hindsight? Next slide, please. So this is equity in program development. We're using intervention mapping because we're trained in it. My team are trained in intervention mapping and implementation mapping, and we've run several workshops now across the world. We started with one in Australia with the developer, you know, the original person, Professor Maria Fernandez of intervention mapping. We've also done one with Nigerian colleagues. We've done one in Malaysia, Johor Bahru. We've done one in Belgium with European colleagues. We've done one also with the Australian Prevention Centre, so TAPSI. So we're continuing these workshops. We're going to do one at the end of the year back in Malaysia. It's a different region of Malaysia, and we are also going to be working with First Nations communities and multicultural communities so that we can continue to build this evidence base. Next slide, please. This is just an example from the Prevention Centre workshop that we ran in Australia. We asked what is needed to embed equity in program planning, and you can see there again, I don't have time to walk you through it, but you can see the richness in information that was derived, and it was literally 2 by 2 hour workshops. So even in that short amount of time, people with vast experience of program planning, implementation, working with community have a lot to input, and we need to all collectively come together, synthesize that information, develop a blueprint and a roadmap so that there is no excuse for leaving any Australian behind. You know, we really need to be focused from the outset on how do we reach Australians equitably as opposed to leaving them behind. Next slide, please. The other thing we did in the TAPSI workshop was thinking about guiding questions for program planners, because the reality is we can have information that says, and there is now information around the world that says, you know, you need to be embedding equity. Equity's become a really major global issue, and how do we do it? We know why we need to do it, but actually we don't know how to do it. And so we need to walk program planners through, implementation scientists through, step by step. Questions are really important to think about so that we can ask ourselves constantly, remind ourselves, are we doing this? Are we doing that? And then when we answer those questions, what we're hoping to do is, if the answer is no, for instance, have guides and resources that support people to reverse that answer to a yes, where equity is being considered and embedded. So that's me. I know I'm sort of rushing it a bit, but I know we're over time. So I'm very happy to talk to anyone at a session, and very happy to continue this discussion. Thank you.
Yeah, thanks very much, Helen, for a fantastic presentation. Really interested in that journey you were describing, both the personal and professional journey, and thanks for sharing all those lessons along the way. Really, really fantastic. So we do have some time for questions now. So feel free to post a question in the chat, or feel free to put your hand up and ask a question. One of the things I was curious about that I could maybe throw to the panel, perhaps starting with you, Andrew, if that's okay. You can't turn around in the sort of research or evidence space at the moment without hearing about how AI is going to have an influence. I'm just wondering what your perspective is on AI as it relates to implementation science and scale up, perhaps, and does it have a role? What's the sort of potential that it might bring? Do you have a view about that?
Yeah, look, I'm actually doing a systematic review at the moment on the design, implementation, and evaluation of chronic disease prevention interventions. So that's with Luke Wolfenden's group and the Prevention Research Collaboration. So it's very interesting about kind of where we are seeing the practical application now, because there is a lot of talk about its potential. But the reality is a lot of it is theoretical at this point in time. So there are a couple of sort of key barriers that we've sort of identified through that systematic review. So most of the actual application of AI in that context is in risk prediction and models for how to predict disease progression, which is a really useful thing. There is some work in the space of machine learning and chatbots. So basically using them as lifestyle behavior change bots. Also in trawling data and making data systems a bit more easy to look at patient records and identify things that may mean that a patient can be sort of more readily identified and prioritised based on a set of characteristics. But I think the ACI, also the Agency for Clinical Innovation in New South Wales, has a living review on the New South Wales Health website, which is really fantastic. And there's a massive list of applications of AI, but when you look at when it's been applied to a health system, there's 2 columns. So there'd be like 300 references, but then there's only 1 or 2 examples where it's been applied. And the challenge is that, a lot of health professionals are less trusting of the technology, don't understand how it can be applied. So I think we're going to have to go through a whole process of really working out what the guardrails are around the application of AI. The consumer is going to have to understand how it's used, but then also clinicians are going to want to be able to use it. And there's still a long way to go. So there are some obvious areas where AI is superior to human performance in healthcare, but there's a whole bunch of areas where it's unclear. In implementation science specifically, I think the whole research process can be expedited quite rapidly by AI. If you look at how systematic reviews are done, how a lot of evidence is gathered, a lot of data analysis. So there's a lot of potential there to make things more efficient. And particularly when you are implementing things at scale, our monitoring systems, how we look at populations and identify who may be at risk or worth targeting, I think there's great potential there. But at this stage, to be honest with you, there's very few practical applications across the whole system at scale, because I think people are still working through what that's happening. And I think the Commonwealth is going through a process at the moment, I'm sure Liz can talk to this, about sort of trying to create guardrails for AI in healthcare. So it's going to be really interesting to see what they are and how it can be done practically.
Thanks, Andrew. Helen or Liz, did you want to add to this topic?
Okay, Helen, I'll jump in because I see you haven't. I think for me, it's a no-brainer in terms of the introduction in the behind-the-scenes efficiency mechanism. So if you think about GP software and a patient talking to their GP and the software writing down what they're saying and then us trawling that sort of information, incredibly powerful, not particularly contentious, apart from privacy considerations and all those sorts of things. I think it is where the AI replaces a human interaction. And so we have seen some interesting stuff. I think it was in the UK, because we're designing, with the prevalence of mental ill health in Australia, we're really conscious we will never have the workforce available for people to see therapists in the volume that they may seek to do so. And so we're obviously looking at more digital solutions. And there was evidence, I think it was from the UK, where they actually demonstrated that a chatbot had more emotional intelligence than a therapist and got it right in terms of the conversation with their client. So how much the community or even the workforce would accept that is a whole nother issue. So I think there's going to be a bunch of research opportunities, and even the health professionals' acceptance of the technology and how it can be used.
Fantastic. Helen, did you want to add anything to this topic?
Yeah, no, great discussion. I think just be really mindful, though, that AI is collating the information and the data that we already have. And that we know is, again, very biased towards a certain demographic. Here in Australia, we don't collect data on multicultural health communities well. We have started since COVID-19, which is fantastic, and we've got a long way to go. So there's missing gaps in our data. First Nations people will tell you that their data and their data sovereignty is not reported in the way that they would want it to be. So yeah, just keeping that in mind. So if we're talking about universal programs, things that we can put out there, and we definitely need to do that. But if we're talking about really tailoring and thinking about, how do we really reach those who we're not reaching, AI might not be the solution.
Thanks, Helen. And,
yeah.
And still looking for questions to arrive in the chat or to people put their hands up. I mean, one of the other things that I think about around implementation science generally is where the capacity building effort might be best placed. So you've all talked about the capacity of what we've learned, like the frameworks that we've developed, the ways of working that I guess been aspiring towards. I'm just wondering if you have a view about where best should we target the efforts to build capacity to better use the evidence and implement the evidence that we have. Maybe I could start with you, Helen.
Well, I think I'm a little bit biased, broken down records. But just to give you context from a global perspective, the Lancet has commissioned a series on global health and implementation science. Equity is a pillar that they're focused on, and they've now recruited me as an international expert because they haven't been able to support that pillar well. So, we really do need to focus, and they are very much now, okay, thank you, Helen, we need to do this, very much focused globally on capacity building in this specific area, because they themselves have realised that if they publish, 3 years of work and they haven't really focused on equity, that's not going to solve those wicked problems that we have in chronic health disease and, the issues that we're facing. So we really do have to build capacity in that area, and we really do need to bandy together collectively. How do we incorporate the voice of lived experience? I know, for instance, Mark Butler at the FECA conference talked about the work that we're doing in cancer screening. The team that I'm leading is doing in cancer screening in multicultural health communities. Basically, we've just given all of the empowerment to the communities. That is leading to better outcomes. That led to increased vaccinations for COVID-19. And, there's a real backing now to actually say we need to partner with, but also to enable that genuine consumer-led work that we know will lead to better outcomes.
So we have got a question, but I'll just check whether Andrew or Liz wanted to add to the capacity building topic before we move on. Andrew,
I think it's, building that capacity and implementation science is an important thing. And I think it's, once again, there are a number of topics that are critical. And I agree with Helen that one of them is the equity focus. We are seeing, since the pandemic, a widening of the gap between rich and poor. But also, I think within the implementation of interventions, when we are trying to implement things at scale, we need to be critically appraise the information to ensure that we're not widening those gaps by, reaching those that perhaps don't need it most. So that's a critical concept moving forward. And how you build that capability, I think, funding agencies, research, my experience in 12 months of academia is that academics will follow the money. So if the funding agencies begin to sort of prioritise implementation science, health services, research, we will start to see more capability and more people getting trained in this space. So I think there's a pretty simple solution for the longer term. But, I think, that we have an implementation science academy, so does Luke Wolfenden's group. There needs to be more of these groups. And I know Helen's group as well as does some training in implementation science. So I think we are starting to see that shift and a focus on this as a discipline. But yeah, follow the money.
Thanks, Andrew. Liz, anything to add to this topic?
No, let's go to the question in the chat.
Yeah, let's go over to you, Nadia.
Wonderful. Thank you, everyone, for your presentations. I've really liked the diverse perspectives that you've each brought, which is really important. When I think about that big gap that you pointed out, Andrew, in implementation and scale up, I'd be really interested in what people think about what are the changes in the system. So this is building on from the question around capability building, but what changes in our system do we need that can support that more rigorous implementation and scale-up approach that we know we need? Noting that it's a fiscally constrained environment, we've got policy silos, we've got working silos between academia and research. So we can see some of those complexities, but what change in the system do you think will support that more rigorous implementation?
Nadia, one thing that comes to my mind is quite often the sort of process is we have a great idea, we implement the policy, we'll do evaluation, it looks pretty good, and from then on, quite often, we're off to the next thing in government, right? We're looking for the next announcement, and you'll see the program be delivered by partners or, the health sector or the community, and it's quite often never revisited. It's assumed that the evaluation from 10 years ago stands today, and it's almost, I used to find this in some of our NGO grant programs, and it's even more in the Commonwealth. It is harder to defund a community program than to fund one, to be perfectly honest, once you've got a bunch of interested consumers and stakeholders. So to me, I think there's something in the process when we establish the organisations who will be delivering them, that they have embedded, and let's not call it evaluation because that'll never work, call it something else around the monitoring about the outcomes of their program, and so that it's in their interest to continue watching what happens to their clients and the outcomes and the changes in health over time, and that then it can be a renegotiation of the program. But there's no seamless way that happens because government will move on. We funded the organisation. 10 years later, they're still getting the same funding for probably a pretty dinky program that's no longer working.
Yeah, I mean, I just echo Liz's thoughts. I mean, I think, in a fiscally tight environment, the reality is if you do want to bring things to scale, you have to think about things that you're going to disinvest from. And that's notoriously difficult to do from a policy perspective, but also in health service delivery. People become quite attached, that they are quite politicised, and, the stakeholders are very noisy, squeaky wheels when you begin to sort of defund. But in that context, also NHMRC and MRFF could provide funding for large-scale system transformations, for example. So, there's a fine line. The Commonwealth can't fund health service delivery, but when you are thinking about how you deliver things at scale, that sort of becomes closer to research. But what we do need is fund the science around how we conduct implementation and evaluate these large-scale system transformations. And we could develop better partnerships with the academic sector to do that in a bit more of a measured and ongoing way. And the other sort of challenge, obviously, within that, I think there's lots of potential with things like the single digital patient record that's being implemented across the country, particularly in New South Wales, as a tool for research and to cut out a lot of the noise. We've been talking about this for decades, haven't we, Liz? But the power of something like a single digital patient record, when it could be used for practice change, but then also research evaluation, that's the sort of nirvana. If we can head there with that, it would be a very powerful tool to sort of do implementation of at scale studies, and we could really see what happens, what changes clinician behaviour, what impact there is on patients, but then also looking at that on a system level. So I think technology would play a key role in that, Nadia, to answer your question.
So We are getting really close to our allotted time slot here, but Helen, is there anything you wanted to add that you haven't got the opportunity to?
No, great responses by Liz and Andrew. I agree.
So, yeah, thank you, Helen. So we do have to finish up with the forum part of this meeting. So really appreciate Helen, Liz, and Andrew your time today, and on behalf of everyone, your willingness to share both your personal experiences and reflections and also your thinking as it applies to implementation science. So really fantastic to have that discussion, and I think everyone really did appreciate that. So thank you for your time.
Thank you.
So we might move on to the Sax Colloquium then, and those of you who are able to stay with us for that would be fantastic if you can do that. So I think Karen is going to set us up on the slides here. So thanks, Karen. So maybe next slide would be great. So the Sax Colloquium is a sort of annual review of some of the activities we've done with our members and some of the work that the Sax Institute has done more generally. And we've tried to tie these Sax Colloquium events to individual Sax forums each year. So the people that are available to take part in this are already on the call. I do have a couple of things I wanted to go through today. One of them is a bit about the purpose of the colloquium itself, which I've started to describe already. I do want to share with you all the new members that have come on board in the last year or so, some highlights generally, as well as some highlights from the Sax Institute's perspective, the financial outcomes for Sax for the year, and some of the things we're thinking about in the year ahead. It'd be important to get your feedback, particularly on the last point about the year ahead, both in terms of what we do with things like the Sax Forum and our Research Action Awards, but also other priorities that you see that we can help support. So next slide, please, Karen. So the main purpose of the colloquium, as I've started to describe already, it is a forum for our members. It is a place that we try and reflect on the highlights and activities of the last 12 months. And it is a place that we start hearing about your suggestions and feedback for the future. Certainly happy to receive any of that feedback today, although admittedly time is now quite short. So if you do have some thoughts about priorities for the future, feel free to email me directly, and my details will be at the end of the slide. And also we can organise a time to chat that through as well. Next slide, please, Karen. So some of the highlights. In the last 12 months, we've had 3 Sax forums. We had one late last year looking at the Global Commission on Evidence work led by John Lavis. We had one in the first part of this year looking at new technologies as it relates to the use of, or the generation of evidence for decision making. And of course, we had today's session on implementation. We also had a really interesting session last year as part of our annual Research Action Awards. That last year we focused on things like health literacy and misinformation and what the research response to that might be. This year we've got a Research Action Awards event scheduled for the 4th of December that will focus on Indigenous health. And all of you who are members would have received invites to that meeting through your organisations. And if you haven't got an invite and you're interested in taking part in that event, certainly do reach out and we can make sure you have the necessary details. We've also continued to have really wide and broad engagement across members of across the Institute with all of our members. And I think that's been really great to see this year, working on a whole range of different things, evidence reviews, evaluations, some of our modelling work, and of course, continuing to use some of our platforms like Shore and 45 and Up. So great to continue to see that. Next slide, please, Karen. So we've also, over the last year, expanded to 82 members of the Sax Institute, which we're really pleased about. We continue to expand at almost 10% each year. I'm not going to go through each individual member that joined this year, other than to say we're really pleased to see the calibre of new members joining the Sax. And if you are aware of groups that would value from becoming members of the Sax, we'd really encourage you to connect them to us. You can do that directly to me, and there's also information on our website about how to become a member. And really pleasing to see that that connection's continuing to grow. Next slide, please, Karen. So some of the highlights from our perspective in the last 12 months from within the Sax. I think there's some important things to share. We've communicated some of these in various forums already, but we have established a new Aboriginal Health Division led by Scott Winch at the Sax, and I'm really excited about the work that we're going to be able to do in partnership with all our Aboriginal health and medical research partners. We have also made an important transition. The Australian Prevention Partnership Centre came up a few times in the discussion today. We've made an important transition to the next generation of that work, and that's being led by Nadia Masterson, who's on the call today as well. We've expanded a lot of our work in the digital twinning space in the last 12 months, and we've got some really powerful tools emerging in that area, particularly around things like mental health and cardiovascular disease, and increasingly looking at the hospital setting as well for some digital twinning work. And so we're really pleased about that. And we're increasingly getting involved in evidence synthesis in what I describe as really complex policy areas. The one that probably got the most attention in the last 12 months has been some work we've done on gender affirming care. And that was really important work done in partnership with a range of university groups, including a group out of Monash that provided a lot of expertise into that review, and really pleased that that was such a positive experience for all involved. And importantly, we've also commenced another wave of data collection in 45 and up. So for those of you who are familiar with 45 and up, it's a large-scale cohort study that's been going for almost 20 years now, with over 250,000 people in New South Wales. The latest round of data collection is focused on aged care and cognitive decline, amongst other things. And again, if that's of interest to you, then please do reach out to us and let us know, and we can get you involved in that work. So next slide, please, Karen. So in terms of the financial outcomes for the FY23-24 financial year, we were going into that year forecasting a deficit position, which was what occurred. We made some important investments in things like establishing an Aboriginal Health Division, in looking at creating some new data assets and looking at some business systems. Oh, sorry, I think you've jumped ahead one slide, Karen. But just to say, we're expecting to realise some of the benefits of those investments in coming years, which will be important and aligns with our strategy and our plan. Next slide, please, Karen. So the year ahead, and this is some of the foundation work that's gone into all of these things is already underway. It'd be great if anyone's interested in being involved in any of this, that they reach out to us and connect, and also great to hear any thoughts you might have. But we are looking at what the next generation of data assets might look like, and what the next generation of longitudinal studies might look like. And I think that'll be really important work for us in coming years. We are talking to a lot of different members at the moment about their methods and their approaches around evidence synthesis. And we think, given that's an area of increasing focus, particularly where there's complex policy areas, we think that'll be a really important agenda for us. I've already mentioned this, but there's an expansion of our work in digital twinning using things like dynamic simulation modelling, and I think that'll continue to be important for us. We've been engaged in a lot of discussions with a number of our members about how to support them in their focus on getting better implementation and impact of their research. And I think that's something we're going to increasingly want to explore, and what are the methods and tools that can help enable that. And I think if you're interested in us connecting with you about that, we'd be more than happy to do so. And then, as I mentioned, we've created an Aboriginal Health Division. One of the key early focuses of that division is how to support some practical implementation around Indigenous data sovereignty. And again, that'll be a big focus for us in 2025. So I've gone through that quite quickly in the time available. I think the last slide, perhaps move to the last slide, Karen. The last slide is really just a call out for any feedback and suggestions you might have. You can, of course, contact me or Genevieve if you want to reach out to us about particular areas that you want to connect with us that we've already focused on, or perhaps suggestions about things that we're not already focused on for things like the Sax forums in 2025 or other activities. So I might just stop there and see if anyone on the call has any particular suggestions or feedback for us at this point, noting that we are a little bit over time, unfortunately. But has anyone got any comments, suggestions, or questions for me at this point? Okay, then it looks like we are done. So we can make this information available to you all, and I'd really encourage you to reach out to the Sax if you have any suggestions or comments about the future programs of work that we're focused on, or indeed the future events that we have planned. Thanks very much for your attendance today. We'll finish up there. Thanks, everyone.